Today's speaker is Ruchika Verma, who is an associate machine learning scientist at AMI. She has recently completed her PhD from the Case Western Reserve University in Ohio, US in biomedical engineering. Before that, she completed her bachelor's and master's in electronics and communication engineering. So she is a machine learning engineer who now works in medical applications for her PhD and now at AMI. So I know that because she is my wife as well. So, so with this introduction, I'll give the floor to Ruchika. So take it away.
Thanks, Neeraj, for introducing me. And I'm glad to be here and share some of my recent work in the applications of machine learning to predict survival and treatment outcomes for cancer patients. Here is a brief outline of my presentation, and I'll start with my first project, which is breast cancer heterogeneity quantification. Breast cancer is the most common invasive cancer in females. First, I'll talk about the data that I used for this project. As we can see here, I worked with the H&E stained images. When a tissue is taken out from the human body, it is usually stained with H&E stain because it's a gold standard in pathology. And it colors nuclei into blue and cytoplasm into pink, as we can see in the right image. These H&E stain slides are usually observed by pathologists to assess the variability in the nuclei size, shape, or arrangement, to assess the tumor grade or stage. Apart from that, these tissue sections are also used for gene expression profiling to identify molecular subtypes. For example, in breast cancer, PAM50 gene expression profiling is used to identify 4 molecular subtypes, which are luminal A, luminal B, HER2, and basal-like. Usually when a cancer is diagnosed in breast cancer, one majority subtype is assigned to a patient, but there are chances that these patients may have coexistence of other subtypes. So because we know that cancer is a heterogeneous disease and there is a high intratumoral heterogeneity. Apart from that, there is a high intratumoral heterogeneity as well. That is, one image could have unique clonal architecture that is spatially and temporally heterogeneous. For example, here I'm showing in the left subsection, there is a majority of one types of cells, as we can see in the left image. In the middle image, we can see there is a majority of other types of cells, but in the right image, we can see that there is a mixed dominance. So this, there is a possibility of having intratumoral heterogeneity in a single patient. Clinical tests and pathology reports usually mention only the dominant subtype, and the treatments which are prescribed based on the dominant subtype and that misses the secondary subtype is a likely factor of treatment failure. In breast cancer patients, approximately 25% of HER2 patients do not respond to trastuzumab, which is a commonly used treatment for HER2 patients because of the potential coexistence of basal subtype. And it is not good to ignore this subtype, although it may be a secondary subtype because it has a higher grade as well as lower survival rate. So there is a need to identify secondary subtype along with the dominant subtype for personalized treatment planning. But before identifying secondary subtype, we need to identify pure tumors to build models, and those models could be eventually used for identification of secondary subtypes. In this work, I used data from TCGA, and for this work, we used 20 patients, each from the 4 subtypes of invasive ductal carcinomas. PAM50 labels were used to build models, and we also incorporated data from different modalities. As you can see here, I used microRNA, mRNA sequence data, RPP, and DNA methylation, along with the H&E stained images. And we made sure to include only those cases which had all this information available. And then we first tried to see if we can identify pure cases using molecular data. So here we created t-SNE plots to create a low dimensional representation of RNA-seq data. And we saw that there were clusters of basal and HER2 subtype. But when we looked at the other modality of the data, for example, RPPA, we didn't see clear clusters here. And we looked at the other molecular data as well, for example, DNA methylation and microRNA. And there we saw that, as we can see here in the DNA methylation, there was a cluster, but some of the patients were misclassified in the opposite clusters. So the patients that seem misclassified in at least one plot, we call those patients as borderline, because there is a possibility of having coexistence of different types of molecular subtypes in these patients. And those are represented here using bounding boxes. And when we build our models, we made sure of not including these patients for training, but using these for testing to see if our model can identify different subtypes in these patients. So for training our model, we made sure of using only pure cases, but for testing, we kept some pure as well as borderline patients. And now the question we had was, can we associate phenotypic observations of HND stain images with the genotypic information that is revealed by molecular profiling technologies? So to answer this, we worked on the HND stain images, because now we have identified pure and borderline cases using molecular data. But then we wanted to see if HND stain images could be utilized to do the same thing, and we have similar findings using HND stain images or not. So to build a model using HND stain images, we sampled patches from the tumor, and these patches were sampled randomly because these HND stain images were too big in size, and we can't keep this data as an input directly into the model. So there was a need to sample patches, and then we discarded those patches where we saw higher concentration or higher area of adipose tissue or background. And after selecting the important patches, we extracted speeded up robust features from these patches. And then we used bag of features approach, because when we use speeded up robust features, we had different dimension of the features coming out from each patch. And to make it consistent, we use bag of features approach that gave us cluster histogram for each patch, and it gave us a consistent length for each patch. After that, we used a classifier that was one versus all to classify basal versus all classification and for HER2 versus all classification. So basically here we trained two separate models, one for basal versus all classification and other was for HER2 versus all classification. After training these models, we evaluated these models using pure cases as well as borderline cases. But here using pure cases, we saw that patches from HER2 patients gave us 84% AUC when we validated our HER2 versus all classifier. Similarly, 91% AUC was achieved by evaluating pure basal cases on the basal versus all classifier. After that, since we had patch-wise classification results, so we created cumulative distribution over patches to assess the HER2-ness and basalness for each patient. So in the in the middle image, we can see there are CDFs. Those were obtained from the HER2 versus all classifier. And in the right image, the CDFs were obtained from the basal versus all classifier. And the colors which are shown in the top of these images shows the patients are coming from which molecular subtype. Here I'm using one of the plot from the previous slide. So this is just for representation of pure testing cases. So as we can see, HER2 patient, which was pure when evaluated using HER2 versus all classifier, more than 50% of the patches showed higher probability towards HER2. And similarly, when we looked at the pure basal testing patient, when following evaluation on the basal versus all classifier, we saw that more than 50% of patches showed higher inclination towards basal class. But when we looked at the borderline patient, which we identified using molecular data, there we saw that it didn't show inclination towards HER2 or basal, because almost 50% of the patches showed higher probability towards HER2 and 50% of the patches showed higher probability towards basal. So there was a possibility of having coexistence of molecular subtypes in these patients. And after looking at the patch-wise results, we tried to aggregate our model outcomes to see patient-wise results. So here in the x-axis, I'm showing probability score of basal versus all detector. And here in the y-axis, I'm showing probability score of HER2 versus all detector. And the patients which were pure basal showed higher probability when passed through the basal-like detector, and it showed lower probability when we pass through the HER2 versus all detector. And similarly, in the pure HER2 patient, we saw that it gave us higher probability score when it was passed through the HER2 versus all detector. And the luminal A and luminal B patients gave low probability when it was passed from both the detectors. But the patients which we identified borderline using molecular data, when we looked these patients using pathology data, we also saw that here also we achieved 0.5 or approximately 0.5 probability from basal-like detector as well as HER2-like detectors. So these are the patients which had higher intratumoral heterogeneity. And we can also interpret this using the figure shown in the right, where the bottom right shows higher probability or pure basal patients, and the top left shows higher HER2 patients, or pure HER2 patients which had higher probability towards which showed higher probability when it was passed through the HER2 detector. And then we also wanted to create heat maps to see if from an ambiguous tumor, we were able to see spatial locations where it showed higher probability towards HER2 or not. And then this whole slide image was passed through the HER2 versus all detector, and we observed that there are some regions where it showed higher probability towards HER2. For example, as we can see here in the red spots, and the blue spots are those regions where it showed lower probability, or there was a possibility of having other molecular subtypes. So this was our finding, that there are some patients which had coexistence of multiple subtypes. And then we wanted to see if phenotypically we saw differences between the patches coming out from the HER2 or basal-like patients. So here I'm showing patches from the pure HER2 class, and in the bottom I'm showing patches from the pure basal-like class. But then we also wanted to see patients whose molecular profiles were not very clearly separated, and it may include heterogeneous patches. So there we saw that the single patient had some patches which were very similar to HER2, and it showed higher probability when it was passed through the HER2 versus all detector. And there were some patches which showed higher inclination towards basal-like. So the detection of a secondary subtype in a single patient is important, and it could be detected using H&E stained images. And in the future, we are attempting to understand the treatment failure in HER2 patients due to coexistence of basal subtype, because we identified image-based. We were able to do image-based analysis to identify these patients who showed coexistence of multiple subtypes in their whole slide images. Now I'll talk about my second project, which is treatment outcome prediction in glioblastoma. First, I'll give a brief introduction of GBM and what treatment is given to these patients. Glioblastoma is an aggressive malignant grade 4 brain tumor with the dismal median survival of 15 months. When a patient is diagnosed with glioblastoma, conventional treatment protocol is maximally safe surgical resection followed by chemoradiation therapy. However, more than 40% of GBM patients do not respond to this conventional chemoradiation therapy because tumor relapse within 6 to 9 months. And these patients are at high risk of poor response to chemoradiation therapy. Thus, there is a need for non-invasive techniques to differentiate these low risk and high risk patients based on the poor response to chemoradiation therapy. And the advantage of identifying these patients using non-invasive techniques is that we could spare them from the adverse effects of the chemoradiation therapy, and they could be suggested for alternative treatments which might be beneficial for them. In glioblastoma, multiparametric MRI scans such as T1, T2, and FLAIR MRI scans are required before treatment. And currently in clinical practice, global volumetric measure is used to assess the treatment response, which is a suboptimal criteria because tumor volume does not capture heterogeneity within the tumor microenvironment. And there is a complex microenvironment within the tumor lesion. For example, in GBM, we can look at the necrotic region, which is the hypointense region on MRI scan, and it represents dead cells, and it is an important hallmark of GBM. We can also look at the enhancing tumor here, which is represented here using the hyperintense region, and it represents breakage in the blood-brain barrier. Or we can look at the peritumoral region, which is also called as edema in glioblastoma. So these three subcompartments are important, and these together are called lesion habitat. And we hypothesize that these subcompartments together create a microcosm that contributes to response to chemoradiation therapy. Now I'll talk about the proposed workflow which we used for this project, and I'll talk about these things one by one. First, I'll talk about the data that I used. As I mentioned that in GBM, T1, T2 FLAIR MRI scans are usually acquired, and that is what we used for this work. And the data was acquired from TCIA, IVGAP, which were publicly available. And we also acquired some slides from the Cleveland Clinic, which was a private institution, and we had a collaboration with them, and they gave some studies to test our analysis on. And apart from that, we also used progression-free survival here because that is our event of interest, and it is just a time to disease progression during and after treatment. And this was used as a surrogate to predict response to chemoradiation therapy. Apart from that, in one of our data sets, specifically in IV gap dataset, we also had histopathology images along with the MRI scans, and we used those some of the data from here. They also provided annotations of different regions, and from H&E stained images, we had histological subsections which were marked by the publicly released data, and they had almost 7 different histological regions marked on the in the intratumoral side, and 4 histological regions marked in the peritumoral region. In total, they had 11 histological regions, and they also provided normalized area of each histology region per patient. And that is what we used later to find some associations of the radiomic markers with the pathology data. After acquiring this data, we did some pre-processing that includes registration, skull stripping, bias correction, and intensity standardization. Registration was used to make all MRI scans isotropic because they were coming from different scanners and sites. Skull stripping was used to remove non-brain areas, for example, eyeballs or skull. And then bias field correction was used to avoid intensity inhomogeneities, and then intensity standardization was performed because there's images were coming from different sites and scanners. So there were variabilities in the intensity ranges, and we wanted to make sure that these ranges should be consistent. After that, we extracted radiomic features from different tumor subcompartments, and those features were gradient, heraldic, laws, collage, Gabor features, etc. And we computed intensity statistics from these features, and almost 1,008 radiomic features were extracted per tumor subcompartment per MRI scan. After extracting these radiomic features, we performed feature selection, and that, in this, first we removed the redundant features based on the correlation, and then we used Cox proportional hazard model to identify important features and did tumor risk stratification here. We looked at the radiomic features from different tumor subcompartments as well as the tumor habitat, and we identified that when we combined clinical features, I'm pointing out what clinical features we used in the right. When we combined clinical features with lesion habitat as well as tumor location, that gave us the best C index as compared to other possibilities which we tried. And here we were evaluating the model performance using C index. After that, we also tried to interpret these radiomic features. We tried to make some associations of the important radiomic features which we identified, and we observed that first of all, I'm showing here radiomic heat maps of a low risk and a high risk patient, and then we tried to make some associations, and we identified that the radiomic features from enhancing tumor were associated with infiltrating tumor and hyperblastic blood vessels in cellular tumor. And these are the histological regions, as per the literature, are responsible for contributing tumor cell invasion to distant areas. So tumor cells move from primary site to a secondary site, and then they start originating again. So that is one of the reason of having treatment resistance, or tumor starts growing again in the secondary site. And apart from that, we also identified some of the radiomic feature association with the leading edge and hyperblastic blood vessels in leading edge. These are the two histological attributes, which is identified in the peripheral tumoral region, which makes sense because the edema is also identified in the peritumoral region. So both are lying in the outside of the tumor region. And this was also known as causing angiogenesis and resistance in the chemoradiation therapy. So these were our findings using GBM data. And after that, now I'm going to talk about my third project, which is personalized survival prediction from pan-cancer whole transcriptome data. This work is ongoing with Professor S. Greiner. And in survival prediction, usually our objective is to predict when an event is likely to happen. But this is not a simple regression problem, because in survival prediction, we also have a sensor bit along with input features as well as time to event, which is time to death here. Censor bit is 0 or 1, depending upon whether a patient is uncensored or censored. I'll talk about what these terminologies are. Let's say we are conducting a study for a period of 5 years. There would be patients who will enroll at different time points, and some of the patients will die within the 5-period time interval. And as I mentioned, that is our event of interest. So those patients will be called as uncensored. In the patient 3, 4, and 5, we can see that these patients, in these patients, we didn't see event, but these patients left the study in between. So we don't know when event happened in these patients. And these are the censored patients. In patient 3, we saw that the event didn't happen even when the study ended. So that is also a possibility of having censored or right censored patients. Here, the objective is to predict individual survival distributions. So that stands for predicting personalized survival probabilities at multiple future time points. Here I'm showing a curve where x-axis represents time and y-axis represents overall survival probability. And using this curve, we can identify what is the probability of survival of a patient at different time points. Now the question is how to learn accurate ISDs for cancer patients. So in this work, we used pan-cancer dataset that contains almost 10,000 tumors, and this dataset contains patients of 33 cancer types. This dataset is publicly available, and it has clinical data, molecular data, as I mentioned here. And we worked with the RNA-seq data that had almost 20,000 genes per patient. First, we performed data pre-processing, where we removed those genes where we had missing values. So after that, in total, we had almost 16,000 genes per patient. Here I'm showing a bar plot to show number of patients we had per cancer type. So the blue bar represents total number of patients per cancer type, and the red bar shows number of uncensored patients out of those patients per cancer type. So in this work, we used a two-step approach where first we learned a low-dimensional pan-cancer representation in an unsupervised manner, and then we learned trained cancer-specific survival models. And here we trained 20 different models based on the using the images from using the RNA-seq data of different cancer types. And these are the patients which we didn't use because they didn't have enough number of uncensored patients for C-index comparison. Now I'll talk about the methodology that we adopted for this. First, we trained a variational autoencoder model that learned a low-dimensional representation from TCGA pan-cancer dataset. So in the input, we used pan-cancer data here, and it had encoder and decoder. We learned a low dimensional representation, and the objective was to minimize the loss here, which was a KL divergence loss and a mean square error. And we wanted to learn the low dimensional representation, which should be able to decode it as close as possible with to the input data. After learning this low dimensional representation in an unsupervised manner, we used this encoder. We transferred the weights which we learned, and we added 2 additional layers using two-layer Cox regression model. And we fine-tuned this model using data from each cancer type. So basically here, we learned cancer-specific survival models, but we did fine-tuning here because we transferred initial weights and then fine-tuned based on the data we had per cancer. And this model was trained using 10-fold cross-validation. And this approach was already published, and we re-implemented this approach from scratch because that was a state-of-the-art approach we wanted to compare our methodology with. And these are the results which we obtained for the 10 cancer types which they reported in the paper. And after making sure that our results were close enough with the results which they reported, we proposed another approach for individual survival distribution. So this approach was based on the non-negative matrix factorization. So here, first, the objective was again to learn a low dimensional representation from a high dimensional RNA-seq data. And that was done using non-negative matrix factorization. And here we learned low dimensional R value was 100 in this case, because we optimized this, and the low dimensional which worked well for us was for 100 dimension. And after learning this low dimensional pan cancer representation, we combined this low dimensional representation with the MTLR model that gave us ISDs. And for evaluation, we used concordance index, and we used decalibration for calibration assessment. Then we compared our approach, which was NMF-MTLR approach, with the VAE Cox model, and we observed that NMF-MTLR consistently performed better in terms of C index in comparison to VAE Cox model. So for 15 cancers, it gave us significant separation, and results were better compared to the VAE Cox model. And we also saw that for 3 cancers, we observed that VA Cox was giving slightly better results in comparison to NMF-MTLR, and those were GBM, low-grade glioma, and ovarian cancer. Now I'll talk about the importance of individual survival distributions in comparison to the KM curves. In KM curves, usually we get average survival curves from a group of patients per cancer subtype. So as we can see here, I'm showing these KM curves for 4 molecular subtypes of breast cancer. But in ISDs, we can see individual behavior, or I would say individual personalized probabilities of a single patient. And we can see that there is a higher intratumoral heterogeneity here, because here I'm showing 3 patients from luminal A, which is shown in green, and 3 patients were shown from the basal subtype, and we saw that there is an overlap of survival, although their molecular subtype was different. And apart from that, when we create this horizontal line at 0.5, we were able to see that the prediction of our model was very close to the actual event time. And then we also looked at 2 different patients, and we compared the ISDs of these 2 patients whose clinical profile was very similar. For example, the age was matching and their stage was similar. They both were HER2, and the same treatment was given to these 2 patients. And we observed that 1 patient died after 3 years and 1 patient was alive even at 7 years. So even the clinical profile was same and the same treatment was given, ISDs could be helpful to assess treatment outcomes and may aid in personalized treatment planning. Currently, we are trying to find biological interpretation of our NMF factors, and seeing that if we could use this to predict prognosis and therapeutic response. Now I'll talk about my 4th project, which is on nuclei segmentation. First, I'll talk about why machine learning is required for nuclei segmentation. As I earlier mentioned, that we looked at, pathologists look at the H&D stain images to assess the variability of the molecular structures. But this is tedious and time consuming, because pathologist has to see different regions of H&D stain slides using microscope, and they have high workload. It also delays diagnosis, and there is high intra and inter-expert variance. So there is a need for objective, quantifiable, and reproducible automatic approach for nuclear segmentation. And there are some challenges for developing algorithms for nuclear segmentation, because in this problem, there are subtle morphological changes. There is high intratumoral heterogeneity, and a lot of different structures are there within a single whole slide image. And there is a variability in the color and nuclear shape in histological images. In addition to that, there is a variability in the stain also, because when images come from different hospitals, they come with different stains. And apart from that, there are overlapping nuclei that also makes challenging to segment these nuclei. And when we did this work, there was a lack of manually annotated nuclear datasets to implement a machine learning model for nuclear segmentation. So we created a dataset here that contains more than 20,000 hand annotated nuclei, and implemented a model for generalized nuclear segmentation. So here I'm showing an example image. In the left, I'm showing an H&D stain image, which was manually annotated as shown in the green with the green boundaries. And in the right, I'm showing one of the ground truth image which we can create, where black region shows background, white region shows foreground, and red color represents the boundary pixels. And this data set contains images from 7 different organs, and we trained our model using images from 4 organs. And for testing, we used independent patients of these 4 organs. Along with that, we also kept 3 different 3 different organs to evaluate the generalizability of our model. So here is a proposed approach. In this work, we first used color normalization because the images were coming from different hospitals. There was a stain variability, and to make sure that model should not learn the color variation, we first did color normalization. And because we had nuclei annotations, first we created nuclei maps, where we created maps for foreground and background nuclei pixels, as well as the boundary maps. And then we created nucleocentric patches. After sampling these nucleocentric patches, we passed it through the CNN model, and the architecture of the CNN model is shown here. The objective was to predict 3 classes. One is inside of the nuclei, outside of the nuclei, and boundary pixels. So after training this model, we evaluated this model in the same way as we trained. First, we use a testing image. We passed it through the color normalization process, and then we sampled patches, then fed into the model, and it classified whether those patches, the center of the patches, represent pixel from the foreground of the nuclei or background of the nuclei, or is it a boundary pixel. And we did post processing afterwards to perform nuclei segmentation. So here I'm showing qualitative performance of our model. So it was good enough to segment nuclei from these images, and there is a high variability in the type of nuclei here. And we also compared this approach with some other approaches. For example, we looked at the cell profiler, Fiji, and we also used CNN2. The CNN2 means we trained another model where we used only 2 classes. One is foreground, one is background, and we didn't include the boundary class. And we observed that the model which were able to predict 3 classes gave us better performance as compared to the other approaches with which we compared. And apart from that, we also proposed an evaluation metric here. Earlier, F1 score was used to assess the detection performance, and segmentation performance was assessed by Jaccard index, but there was not a unified metric that penalizes both under and over segmentation errors. So we proposed a new metric here that was aggregated Jaccard index, and we evaluated our results using all these metrics, including aggregated Jaccard index. And here I'm showing some of the results which are coming from the images from kidney and colon. In the left here, I'm showing one image per cancer type that we used. The top row shows H&E stain images, and in the second row, we are showing the annotations which we performed. These are the manual annotations. And in the third row, I'm showing the boundary maps, which are the ground truth maps. And the fourth row shows the images after color normalization, because that is the pre-processing step. And we made sure that all images should be of similar color. And then we passed it through our model. And in the second last row, we can see the model outcomes. And the last row shows the segmented results, which are close to the ground truth data. And here in the right, I'm showing the values which we got when we tested different images from different cancers using AGI. And our aggregated or average AGI value was 0.5 for this work. This dataset is publicly available. This algorithm and the code to compute AGI is also available, and it's available in the webpage given below. After that, we organized one challenge, which was multi-organ nuclei segmentation challenge. And this challenge was organized at MICAI in 2018. Neeraj, I and collaborators from IIT Bombay worked on this, and we created a new data set for nuclear segmentation. So the data set which we created contained almost 31,000 nuclei and annotations. So as I mentioned that earlier, we had almost 21,000 nuclei annotations, and in this work, we created additional 10,000 nuclei boundary annotations, and we also included 2 additional organs. For example, lung and brain was included for testing the generalizability of our model. And the data was publicly released initially to the registered participants, and they prepared their algorithms and submitted their work, and we evaluated their algorithms using AGI. The testing annotations were not initially released. We withheld initially to compute AGI, and after that, this whole data set was publicly released. And the information about the algorithms is available in the paper given below. And this data set is publicly available on the challenge webpage, which I'm showing in the right. And the highest AGI which the winner got was 0.69 in this work. After that, we were also interested in classifying nuclei, because in HND stain images, there were a lot of nuclei which were of different classes, and they had different role. So we prepared another kind of data set and organized this challenge, which was multi-organ nuclei segmentation and classification challenge. And this challenge was organized at ISP in 2020. Here we publicly released data from 4 nucleotypes. One was epithelial, lymphocyte, macrophages, and neutrophils. In the right, I'm showing one of the ground truth masks, which we could create using this data set. Different colors shows nuclei from different cell types. So here I'm showing the total number of cells that we annotated. So as I mentioned that here, our interest was 4 different classes. One was epithelial, other was lymphocyte, some neutrophils and macrophages. And this data set was created using cancer images from 4 different organs that were lung, kidney, breast, and prostate. So in total, we had almost 31,000 nuclei annotations along with the marking, along with the class information for training the model. And for testing, we created additional 15,000 nuclei annotations. But for testing, we also created additional annotations for ambiguous regions, as I'm showing here, because there are some nuclei classes which we were not marking. For example, fibroblast, we were not marking those kind of nuclei, or there were some faded nuclei. And when the challenge participants submitted their algorithms, we didn't want them to penalize for those classes which we didn't, which were not of our interest. So we excluded these regions and we released these annotations publicly so that this region will not be included for evaluation metric. And these are the challenge organizers. So this challenge was organized with collaborators of IIT Bombay as well as Tata Memorial Center from India. In this, so we had almost 170 registrations. Out of those, 88% were from universities, and we used panoptic quality here to assess the performance of nuclei segmentation and classification. And the winner team was TIA Lab from University of Warwick, and they got 0.61 average panoptic quality. They were also awarded a GPU by NVIDIA here. After that, here I'm showing one of the image to show results from different teams. So the top row shows 2 images from different cancer types. And here in the second row, I'm showing ground truth results. And these are the segmentation and classification results which were obtained from different participants. And the winner team is shown in the third row, whose results were very close to the ground truth, although there were some missing nuclei, as here we can see the missing neutrophil. The code to create these binary masks and the data is publicly available, and the algorithms are summarized in the paper which was published in TMI. At the end, I would like to thank all the collaborators, colleagues, and professors who supported and helped me getting this work done. Thank you. I'll be happy to take any questions if you have.
Thanks, Ruchika, for the presentation. If you have any questions, please feel free to unmute yourself and ask questions directly to Ruchika, or you can type your questions in the chat box, and I can read those for her. So I see Cam has a question and Namita also has a question. So
oh, sorry, I didn't have a question. I just had applause. That was fantastic.
Thank you.
thanks.
Hi, Ruchika. It was a very good presentation. If you go to the beginning, you were talking about the random patches and adipose tissue. So, like, very first project of yours.
This one.
Yeah. So you said that you're selecting the random patches based on the concentration of the adipose tissues, right? So how exactly are you, trying to calculate, or how does that happen? Like how do you see or infer that this region has higher concentration of the tissue? I'm not sure how you do that.
So first of all, I just want to clarify the patches were randomly sampled from the tumor region,
Okay.
as shown in the middle. And then we selected patches which should not have large amount of adipose tissue or background. And that selection was done based on the H&E stain separation. Because when we used color normalization, we were able to do stain separation as well. And from the hemotoxylin stain concentration, you can get to know that this is the image where we have higher concentration of nuclei and not a background or adipose tissue.
Okay. Okay.
And we can also,
yeah, please continue.
Yeah, you can also convert that into another, like rather than RGB space to LAB space, and that could also help in like filtering some of the images. So that is another approach which could be applied here.
Okay. And the second question is, you said that you're using clustering, I guess, in the next two slides somewhere. Yep. Okay. I just wanted to see because, I mean, you changed the slide like pretty fast. So I just wanted to see what of clustering you're using. Okay. So you're using the k-means clustering here.
Right. So this is a bag of features approach which uses k-means clustering in between it. Like, so once you'll have features, you can use a bag of features approach which uses k-means clustering, and then it bins your features to like, if let's say you want to create a histogram of 1000 dimension, it will bin your features depending upon which feature lies to which k class, and it will keep on counting and create a histogram out of it.
Okay. Okay, that's cool. And for the HER2, the ones that are in the gray zone, yeah. So for those, I guess we use the FISH to confirm whether they belong to the positives or the negatives, something like that. So did you automate that process, or did you rely on the FISH test?
So here we just looked at the molecular data, because that's how we identified that these are the ambiguous biopsies, and then we evaluated using H&E, but we didn't have the FISH data to confirm it with, but that could also be a possibility.
Okay. Okay. And sorry, I have a lot.
Sorry, I want to add here. So we had HER2 score and FISH available in the clinical information sheet. So we use that information.
Oh, okay. Well. Okay. Okay, yeah, that makes sense. So after, I guess in the second project of yours, you were talking about radiomic feature selection and extraction, right?
Yes.
So you performed something called as tumor risk stratification, if I'm not wrong. So could you shed more light on that? I didn't get that actually.
So we just use Cox proportional hazard model, and then we used a median survival information to dichotomize it into two classes here.
Okay, so the C index is the concordance index is what you're saying. Okay,
yes.
Okay. Okay. And the last project, nuclei segmentation. Yeah. So you said that you had to rely on the manual annotation here. Did you explore other softwares like Stardust or Elastic, something like that, or along with Cell Profiler? There is QPath as well, if I'm not wrong.
I
So
think
Funny thing
when
is,
yeah.
QPath
Sorry.
actually uses this data set to build that software. It came
oh,
quite
okay,
later.
Yeah, I was also
okay,
going to say that this work was done in 2017, and I'm not sure if QPath was there
okay.
at that time. Yeah.
Okay, that's great. That's great. Also, I mean, considering it was done back like 5 years ago, do you have any extensions of this, like trying to not rely on manual annotation or implementing certain attention techniques, or some Gaussian masks or some binary masks that you're generating? Like, are you planning to do that, or have you already done that?
So I think we like for nucleus, like we extended it using these two competitions, monoseg and monosag.
Okay.
There we know that what algorithms worked for this and which didn't work. So from that idea, we can move forward. But I think now we are more interested in nuclear segmentation and classification, because I think we are getting enough performance with the nuclear segmentation, because in the nuclear segmentation classification, we can assess the tumor microenvironment, because we know what types of cells, like let's say what is the concentration of immune cells. We can use that to build further or identify prognosis or treatment response in the later stage.
Okay, that's great. Thank you so much.
Then we have David Murray. David, please unmute yourself and ask questions directly.
Okay, can you hear me okay?
Yes.
Yes, perfectly.
Oh, good. That was a lovely talk. Thank you very much. It was interesting all the way through, but you really got my attention right at the end when you started talking about this ambiguous category of cells. Because we've been working for some years in an area where we do see very unusual cancer cells, and other people across the world that have variously been called heterokaryons or endopolyploid multinucleated giant cancer cells that certain people think have a major role in cancer carcinogenesis, tumorigenesis, and in treatment response. Could you elaborate at all on what your view of these ambiguous population were? Because people often throw things out because they're ambiguous, but sometimes they turn out to actually be really important. I wonder if this is a case with your data.
I would say here, like here our interest was to focus on 4 classes, but the other classes which we are discarding or not including right now, it doesn't mean that these classes are not important. It's just like while creating this data set was at that time our focus was on 4 classes, because we were interested to move forward with the immune cell assessment.
Yeah,
I
see what you're saying there.
I would also add to that, these annotations were done by like engineers like us in collaboration with pathologists. So we understood 4 classes, and then we also tried to do this fibroblasts and other things, which were like really difficult for us. So we thought that, okay, let's focus on those classes which we understand and which we can phenotypically see on a slide and annotate those. And then we can move on. There is one data set that did like fibroblast and other types of cells that are important and to capture the field effects and other things. But in this case, we just focused on 4 classes.
Even in neutrophils,
that wasn't
meant
as a criticism. I mean, are any of your pathologists out there in the audience today that perhaps could comment on, from a pathologist perspective, what those areas of unusual structure looked like?
So we have 2 pathologists.
Or maybe you could send me an email and I could have a chat with them online. I'd be really interested to see what the pathologist's perception of these areas was.
Sure.
Sure, I think we can talk about it offline, because I think we can, like with the help of pathologists, there could be some other possibilities, or they can shed more light on this.
Yeah, that would be great. Thank you.
Thank you. Any other questions?
Yeah, just a small follow-up. So have you tried the primitive methods of, Bernoulli diagrams or the minimum spanning tree to check the, representation of these tumor cells? I mean, have you explored those baselines?
I didn't explore that, but where I was doing PhD, there some of my colleagues were working on that area, and they try to use Voronoi diagram and other things
Okay.
to extract feature maps.
Okay. That's great. Thank you.
Please feel free to unmute yourself and ask questions directly. David, could you please send us your email in the chat box so that we can reach out?
Certainly will. I will look forward to that.
Sure.
Thanks.
Okay, if there are no more questions, let's thank the speaker and we will see you next week. Ruchika, thank you so much for volunteering for today's presentation. It was really great and enjoyed the discussion. I hope everyone enjoyed discussion with you. I don't see your email here in the slides. If someone wants to reach out to you, could you please type in your email? And yeah, here it is. So Ruchika's email is in the chat box. So if anyone wants to reach out to her, please feel free to email her directly. So thank you so much, Ruchika. Stay safe, everyone. See you next week. Bye-bye.